The presentation of eagle syndrome is in two types. One is the classical eagle syndrome, where ipsilateral dull and persistent pharyngeal pain centered in the ipsilateral tonsillar fossa, referred to the ear and exacerbated by rotation of the head. There will be a feeling of a mass or bulge may be palpated in the ipsilateral tonsillar fossa, exacerbating the patient's symptoms. Other symptoms include dysphagia, sensation of foreign body raw, tinnitus, or cervicofacial pain. Then the other syndrome is stylocarotid syndrome, where this enlarged styloid process compresses the either external carotid artery or internal carotid artery. With their perivascular symptomatic fibers, sympathetic fibers are also get irritated by a laterally or medially deviated styloid process. It is related to a pain along the distribution of the artery, which is provoked and exacerbated by rotation and compression of the neck. In cases of impingement of the internal carotid artery, patient often refers to supraorbital pain and parietal headaches. In cases of external carotid artery irritation, the pain radiates to the infraorbital region. So, supraorbital pain and infraorbital pain differentiate between external and internal carotid artery involvement. So, how we work up? First, we do it, confirm it clinically by palpating the tonsillar fossa with fingers. And on palpation, patient will have same pain exaggerated on pressure. Then we inject local injection like dilopen or sensorican, and again palpate, the pain will vanish. Then we confirm it by orthopantogram, and if we go for 3D reconstructed CT scan of temporal bone, this is the most diagnostic, but it is expensive. In fact, I ordered for one person, and he came with some other type of report. So I stopped writing CT scan for this.
You are not sure. You are still getting your expressions. No problem.
There are many other investigations for further management of this disease, like we have to get GA fitness, so for that we have to do all other investigations. Then management may be medical management or surgical management. In medical management, we give analgesics. If it is early disease, he may improve, he or she may improve. Then we give some neuroprotective vitamins like methylcobalamin, but role is still debated. Anticonvulsant may be tried like trigeminal neuralgia, we give carbamazepine. Antidepressants may be given. Then these are only symptomatic. For a definitive management, we can try steroid injection with long-acting anesthetic agent, bupivacaine, in tonsillar fossa. We have tried in some patients with some benefits, but more or less most of patients get this recurrence once again. So the definitive management is surgical treatment. So initially we try medical management. When it fails, then we go for surgical. It can be intraoral approach or extraoral approach. Intraoral approach में we remove the tonsil first, and after that we just split the tonsillar bed to expose the tip of styloid process. Then remove all the soft tissue attachment from the styloid process and break it. Then the newer methods are with the help of laser. If it is large enough and we have got laser, so with limited opening of the styloid region in the anterior pillar of the tonsillar fossa, we can remove it easily. Then extraoral approach is through the cervical neck incision, and it is mostly it is abundant procedure. Earlier it was done, nowadays nobody does it. So advantages of this intraoral approach is avoid external scarring, less time consuming. And a lot of disadvantages are written, but most of the people are doing intraoral approach. The invent of laser, it has become much easier. Risk of deep space neck infection is there, poor visualization of the cervical vein, major risk of hypertrophy due to main neurovascular structure, poor hemorrhagic control, alteration of speech and swelling for post-operative edema, difficulty fetching markedly decreased jaw. And extraoral approach has also got some advantages like better visualization of the surgical field, greater intraoperative stability. Then disadvantages are more time consuming, risk of injury to facial nerve structures, facial nerve and structures, neck scar, and longer recovery time. these are complications. This may be deep space neck infection due to very neurovascular structures, hemorrhage may be there, and temporary alteration of speech and swelling following the surgery. Outcome and prognosis, the overall success rate for treatment, medical or surgical combined is about 80%. The failure of treatment may be associated with the presence of other causes involved in the pathogenesis of the problem. Another very common cases recently we started diagnosing is contact point headache. It takes only 5 minutes to me. Its other names are Sunders neuralgia, anterior point neuralgia, pterygopalatine ganglioneuralgia, sphenopalatine ganglioneuralgia, and these are analogous to leg sciatica but of the nose and face. These are endoscopic pictures taken by our hospital. This is, we can see septal one bony septal cartilage is projecting here. It is very sharp and touching the lateral wall of the nose. This is another picture. Septum is deviated here. Here we can see two structures. Usually we see only one structure. So this thing is enlarged at bulla. Here this area is touching. So this is another contact point. This is another picture. This is the original picture. After giving the decongestion oxy spray, the congestion has decreased and there is space. So pain has vanished. It is extremely frustrating headache, untold suffering for numerous patients, unrelenting sharp or stabbing pain in a single localized spot on their face. Not unusual for a patient to go for years without a diagnosis or good treatment plan that works. Before being diagnosed, they might have visited neurologists, CAT surgeons, dentists, oral surgeons, spine specialists, all without pain resolution. And many medications might have been tried, like antibiotics, nasal sprays, neuropathy, medications, steroids, narcotics, muscle relaxation. Single base relief is an over-the-counter decongestant, which decongest the nose and contact has been removed, then pain will subside, but it is only temporary. MRI and CT scan might have been done without any sinus infection or any tumor. So patient may even be told it is all psychological and very bad type of neuropathy, but it is not treatable. Usually there are some certain pattern of this contact point headaches. Usually the pain started after an upper respiratory tract infection. Pain localized to a single area on the face on just one side. Pain classically described localized to cheek and or between nose and eye, but can radiate to other locations. Pain can also be localized to upper teeth and roof of the mouth, depending on the involvement of the nerve or ganglion. Pain described as sharp or shooting, less commonly as pressure, like syndrome driving a high heel into the face. May be associated with light and noise sensitivity. Not uncommon for this patient to be erroneously diagnosed as migraine without aura. Decongestion seems to work the best to resolve headaches, but only temporarily. This is a typical picture of contact point headaches. So these are nerves which get entrapped in these contact points. This is anterior ethmoidal nerve, which is a branch of ophthalmic nerve, of trigeminal nerve. It supplies the part of septum and lateral wall. So the pain comes in the between ear and nose, this area. Sometimes nasal area also have some pain. This is pterygopalatine ganglion, and from here so many branches coming. So pain will have patient will have pain in the cheek region, sometimes in the anterior part of teeth and hard palate area. So how to work up for this contact point headaches? Complete ENT evaluations should be done with nasal endoscopy to confirm the presence of structural problem like septal spur, septal deviation, then concha bullosa, any other tumor. CT scan to ensure that there is no underlying sinus pathology or anatomic bony irregularities. CT may be additionally be recommended if sphenopalatine ganglion neuropathy is present with endoscopic suggestion of possible skull base tumor. Then MRI scan is usually obtained by neurologist to ensure no underlying brain or spinal. And then depending on the nasal endoscopy and CT scan findings, a diagnostic test of sort of can be performed in office where we put some local anesthetic spray to the nose, and after that patient will have no pain. First we give decongestant, then this local anesthetic, and we can also do by endoscope. Now we can touch that contact points and get this patient exaggerated. And that treatment is mostly surgery, because medical management is only temporary. So for medical management we give decongestant, nasal decongestant, and surgically we remove the structural problem. If it is problem in the septum, then we go for septoplasty, and if it is concha then we have to sort out that. Sometimes this surgery also not help, then we go for sinus surgery. And in rare cases there are less invasive options that can be considered, as well injections like the local anesthetic with steroid we can inject, where in such case where surgery is not indicated, like old age person not willing for surgery.